No, but we need you to stay for your laugh track.
We could just play that
in. Yeah, we'll do that. Just have Chris.
You know, Nick's gonna put this in as the
Dr. Gill's
as the intro.
canned laughter. Laugh track.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast. For anyone who is as confused by the latest health study as I am by Greenwich Mean Time. So we are here in London. I went down to Greenwich. I got to see the Prime Meridian. And yet for the life of me,
that's kind of beef, right?
What's that?
That's a kind of beef. The Prime Meridian?
No. But I see where you're going with that. But I still, for the life of me, cannot figure out how to get Outlook to put the right calendar time in when I try to schedule a meeting.
It all comes down to Outlook.
You can't do that. It's like Maine. You can't get there.
What is it the mean of? That's my question.
Just they were very unkind.
Yeah. Why isn't Greenwich Median Time?
Yeah. Why is it mean? I mean, it's sort of implies it's the summation of a whole bunch of other times.
It's on average the same time all day long.
Now I'm gonna have to go back and ask these questions.
Yeah. Get back to us on that, Matt.
All right. Well, I'm Matt Fox from the Departments of Epidemiology and Global Health, and I'm here with Chris Gill and Don Thea.
Hello.
Hi.
From the Department of Global Health at the BU School of Public Health. And as always, Don and Chris are in the Godly Studio. I am still here in London trying to figure out Greenwich Mean Time. So we are getting closer and closer to summer, which means that we will have the Summer Institute of the Population Health Exchange. And for those of you who are interested, head over to the Population Health Exchange website where you can find the summer programs that are going on. That is BU's hub for lifelong learning.
Don't forget the recipe page.
What's that?
Don't forget the recipe page where they teach you how to make all those summer coolers.
I see. Chris apparently has been editing the web. Chris, the website is not Wikipedia where you can just go in and make it say whatever you want.
Oh.
It is a real website.
What?
And as a reminder, please go onto iTunes and give us a rating. Guys, did you see there was a bump up in our downloads from France?
No.
I went and gave a talk in France, and immediately afterwards we got a bump up in downloads.
Really?
So,
Wow.
Yeah, so I think you guys need to go out and
maybe we should give ourselves a French toast.
Oh, and there you go. And there we lost all of our French listeners.
Le podcast plus meilleur de la monde.
I don't know what that means, but I will agree to it. So now,
best podcast in the world.
Onto the show. So today, in our first segment, which is our Journal Club segment, we are going to look at the impact of sunset time on health. Then in our second part, which is our deep dive, we will talk about something else because I didn't write down what it was this time. Does anyone remember what it was?
No,
we don't.
I did. It had something to do with pragmatic trials and informed consent.
No, it was a pragmatic trial. So it's whether low risk trials can be done without consent.
Yeah.
And then in our final segment, which is our amazing amusing, we'll get into some of the things that made us laugh out loud, or Don will explain to us what is in our belly button lint. Thank you, Don.
It's naked mole rats.
It better not be. Oh, good Lord.
Can you imagine anything worse?
See, here's the problem. Here's the problem. So we record this. It's like what? 3 p.m. your time?
Yeah.
But it's 8 my time, so I have to go to bed after this. Well, not right after this, and now I'm going to have nightmares about naked mole rats. So thank you for that,
Swimming
Chris.
around in your belly button.
They come in the dozens.
Anyway, so segment 1.
You can't have one. They come as a pod.
As a family.
Right.
Okay. This is
Wouldn't it be
over.
an exaltation of mole rats?
Yes.
Not
Is
a
that
pod?
the term?
I like that.
Oh, gosh. All right, so segment 1, we're going to talk about an article that looked at the impact of sunset time on health. It was published in the Journal of Health Economics, so it's a little bit outside of our usual go-to type journals in that it was an economics journal.
And really long.
But I liked it all the same, though. So it was titled Sunset Time and the Economic Effects of Social Jet Lag, which is a term I'd never heard before. Evidence from U.S. Time Zone Borders by Osea Gintella from the University of Pittsburgh, and also Fabrizio Mazzano. Oh, I'm terrible with names. Mazzonov, something like that. So here are the headlines for this one. So the Duluth News Tribune says, living on the wrong side of a time zone can be hazardous to your health. The New York Post says, living on the wrong side of time zone can be damaging to your health. I think they were copying each other. CNN says how permanent daylight saving times and later school starts could affect your health. And the Medical Health News says, experts, permanent daylight savings time could affect health. So at least they were consistent.
That's not what the article said.
No, but this
It didn't say anything about daylight savings time.
Well, they sort of did.
No, it's about time zones.
No, they referred to daylight savings time in the
They
introduction.
mention it, but it's not about that.
I would agree with you. Don, explain this study to us and recognizing that this was an economic study, so it's going to be a little bit different from what we're normally used to.
Not talk about any formulas.
Yeah. No formulas. Yeah. No, I want to dedicate this to one of my favorite quotes. Oh. And this is a quote by Dr.
Quote from the paper, or one of your favorite quotes of all time?
One of my favorite quotes of all time.
Is it from Game of Thrones?
No. This is a quote from Dr. Chris Gill.
Oh, no.
I dream for sleep.
That's a good one.
When did Dr. Gill say this?
Remember?
Yeah.
When did you say this, Chris?
Recently, I think.
Yeah.
I was very tired.
Oh.
All right. So in any event, this one was a little hard to unpack. But basically, this is another regression discontinuity, similar to the one that we did previously when we looked at the difference in ADHD among children who were born on either side of the cut point for getting into kindergarten. And so it's sort of a natural experiment where you've got two very homogeneous populations that have one characteristic that is completely different. And in terms of the kids, it's when they were born and whether they get to go this year or next year to kindergarten. And in this study, what they did is they looked at populations of people living on either side, within 250 miles of a time zone in the United States. And they chose the three times, there's 4 time zones in the United States and therefore 3 boundaries. And they looked at the time zones along the 3 boundaries, which can go between states or can go down the middle of states and distinguish districts from one another. And by definition, people who live on the eastern portion of the time zone have 1 hour, are 1 hour later than those who are on the left side, the western side, and 1 hour more of daylight. And one thing that I didn't know is that, and they made a big deal of this.
Is that backwards?
No, I don't think so.
Backwards, because as you go, the furthest most western point.
I read it and I put it in bold to make sure that I wasn't going to get it backwards.
Anyway, we get the general idea.
Yeah. And then the other input that they said was that that may contribute to your evening routine was that the main TV shows, the primetime TV shows, are at, say, 9 o'clock on the East Coast and on the West Coast, but in the 2 middle time zones, they're at 9 o'clock. So that would affect people's...
8 o'clock on the East Coast and West Coast, 9 o'clock in the Central Mountain.
Right. Or 9 and 10, yeah, but earlier in the Mountain and Central time zones. So what they did was they used several data sets, one of which was American Time Use Survey data set, which is conducted, I guess, yearly by the U.S. Bureau of Labor Statistics. And they looked at a 10-year period from 2003 to 2013. And they also did looked at current population survey, which is a CDC data set in the same areas that they were surveying that looked at certain health outcomes. They also had behavioral risk factor surveillance system data set, and they also looked at the National Cancer Registry. So the way the time use survey works is that people are asked to fill out a detailed time use diary of their previous day's activity, time spent sleeping, eating, and the total sample for that nationwide survey is 148,000 individuals. But these authors restricted their analysis to individuals who were actually in the labor force, living within 250 miles of each time zone boundary, so Pacific Mountain, Mountain Central, and Central Eastern. They also merged that, as I said, with the current population survey data set from CDC, which does not contain county information for individuals living in counties that have fewer than 100,000 residents. Therefore, they could only match 44% of the sample, and the result was it was a more urbanized sample that ended up getting into the data set for being analyzed. They restricted it to individuals who were between 18 and 55 years of age, i.e. they omitted people who were likely to be retired or high school workers. And they ended up including 18,000 individuals, of whom 16,000 were employed. And they did those three comparisons. And they also did comparisons stratified by latitude, because the days are longer in the north in the summer and shorter in the north in the wintertime than in the south. So they had to account for those differences. And their primary outcome was night sleep duration, or the amount of night of sleep at night that was lost. And their secondary outcomes were health outcomes, which were obesity, diabetes, acute MI, stroke, breast cancer, prostate cancer, and colorectal cancer. And they kind of put all of those together to make a sort of a health measure index. They looked at covariates such as age, sex, education, race, marital status, year of immigration, and number of children, and also BMI and self-reported health. But that was not available for all years. The bottom line is, when they did a comparison of individuals who were in residence to the west of the time zone versus those to the east, the ones who lived on the east side of the time zone had a longer day, a longer period of light, in essence.
Later sunset. I guess.
Later sunset, right. Later sunset. That they got 19 minutes less sleep per night than the comparable population on the left side.
And it was worse too for like people who had jobs that required them to get up in the morning.
Right.
And then
it was
they had
exacerbated.
30 minutes less sleep on average.
Yeah. So if you went to bed later, but you commuted to a job that was, where you had to get up earlier, it exacerbated this issue. They also found that the sleep quality that they measured was more restless, and that people woke up more, but by very, very small margins. And in terms of the health outcomes, where they aggregated the health outcomes by combining those studies, but the health outcomes, it wasn't per individual. It was really, as far as I could tell, was the health outcomes kind of aggregated within a particular district associated with being on the west or the east side of the time zone. They found that there was excess weight, there was more poor health status. This is all if you're living on the eastern side with the later sunset. Composite health index was 0.3 standard deviations lower, and that the wages were 3% lower. 11% were more likely to be overweight, and 5% more likely to be obese.
So
there were health consequences.
Bad.
Yeah. So if you're living on that eastern, the late sunset side, you seem to have marginally worse health outcomes, and you're sleepier.
Chris, you sound surprised. Did you in fact read the paper?
Oh no, I did read the paper, and I liked this paper. I thought it was very complicated.
So give us your take on it.
I was going to mention that there was another outcome that was included in that they called the back of the cocktail napkin or the back of the envelope economic
Which I thought
analysis.
was amazing to read in a scientific paper.
Yeah, and
they actually referred to it as, we just did a back of the envelope calculation.
Particularly in an economics paper,
right?
The most clearly economic part of this was the part that they
on the back of a napkin.
Kind of winged the most.
It's true. It was not a very economics-y paper, other than in the way that it was
set up.
We could talk about it, but the way it was set up and described.
I thought the whole thing was super clever, and actually I was quite persuaded, and I was also curious, how wide is a time zone? Because I had sort of assumed that time zones were set to be about an hour wide, but that turned out not to be true.
Have you ever driven through Nebraska?
Oh, yes.
Forever.
It takes forever. It does. So do you guys know offhand what is the easternmost point of the United States where sun is seen first?
It's in Maine.
Yes,
it is.
Acadia National Park.
It's north of that. It's Lubec, Maine.
Cadillac Mountain.
Well, that could be true, but I guess at sea level is what I would say. So standardized for sea level.
I don't know.
So the answer is Lubec, Maine, which is way up just on the border with Canada, and it kind of juts out far east. Yeah, it is very far east geographically. And then if you go for the westernmost part of the Eastern Standard Time Zone, there's a little piece that kind of nudges over just in Michigan, but there aren't a lot of people who live up there, so there's very few cities. So the most sort of practical, because the time zone is not straight up and down. It's very wiggly. It crosses state lines and follows rivers and does all sorts of weird stuff. And so one of the furthest west parts of that same time zone is Terre Haute, Indiana. And so the time difference when Lubeck sees the sunrise today, and I measured today on Google, is at 5:19 a.m. is when the sun rises in Lubeck. And the sun rises in Terre Haute, Indiana at 6:52 a.m. So that's an hour and 42 minutes later. So it's actually a really striking difference. So they have an hour and 42 minutes more darkness than the people who live on the far eastern part of...
No. They have the same amount of darkness. The
same
darkness
but their day starts an hour and 42 minutes later. Then
they actually don't have the exact same because they're further south, but yes.
So like when we're up and like running about and like, getting busy and doing stuff and starting our day, it is pitch black for an hour and 42 minutes over there.
Who runs about?
Well,
Don't you run two or
lobster fishermen for one.
Okay.
And potato
you run
farmers.
Around, you run two, you run under, you
potato
run
farmers.
And there's an even more whack example of this, which is China, which is about the same width
you
of the United States.
mentioned, and I was shocked by this.
Time zone for the entire
That's
country.
crazy.
And it's Beijing Standard Time across the entire
That's
country.
crazy.
So like the people in Xinjiang, they've got like 5 hours of darkness while Beijing is up and bustling. It is.
And there's, do they shift their work schedules to account for that?
I don't know how they deal with it, but they must do something because it just seems crazy.
It certainly doesn't seem to have an effect on productivity.
Yeah, well, I guess so.
Okay, anyway,
I thought this was a really clever analysis, and I have to say I was kind of persuaded for it, with the exception of the economic analysis, the back of the envelope one, which I didn't quite buy, because they were basically making the case that this sort of loss of sleep that you get when you're on the eastern side of the time zone, right? Of the timeline. If you're just on the east side of that, like you're the Terre Hautes, right? You are penalized and you get 30 minutes less sleep and you have these health outcomes. And that translates into some degree of worker absenteeism, which then they plugged into some model and came up with some economic cost on the order of $700-800 million a year or something like that. So there was a lot of money. But wouldn't you also argue that loss of productivity is compensated for on the far east side of the time zone, where they would actually
they
benefit from
restricted
this?
it to 250 miles around the time zone.
I understand, but like that the argument that there's a penalty in labor loss on the western side surely is balanced by the benefit on the eastern side. So I just felt like, wouldn't that actually just be a wash in the end? I don't know. I mean, what did you guys think about that?
I'm not sure, but that part I found the least interesting and persuasive part of the entire paper. But I will say, so I Chris, like you, I really liked this study. I found it so clever and such an interesting way to attack a problem. And I think that I enjoy these and I like these alternative approaches to getting at causation by sort of using these
natural experiments.
Yeah, you call it a natural experiment, I think is a fair way. And yet I was not totally persuaded by this one, much as I loved it. Part of the reason I'm not totally persuaded by it, and by the way, I should say I'm not persuaded by it, and yet I think they did so much work with this paper. They thought of all the criticisms. They came up with answers for so much of it. They did all kinds of different analyses to solve some of these problems, and yet it still left me a little bit lacking. And so what I mean by that is that I'm reasonably confident in the sleep measure. So they have this measure of sleep, and they essentially, are comparing people very close to that border and saying, if you're on one side or the other, you should be roughly randomized. I'm not sure I totally buy that argument that you should be randomized living on one side of the border or the other. Now they make the people who live on, one side of the border may be very different from people who live on the other side of the border. And that could be just because, it just happened, neighborhoods can be very, like if you're in DC, let's say, you go from one neighborhood to the other and you can be in vastly different socioeconomic status. Boston is the same, New York's the same, these are not necessarily in cities, but even in, different, more rural areas, you come up with reasons why people live in particular places that are might just be different on one side or the other. Now, I don't see that in the data. They present data that would suggest these are reasonably comparable populations, and yet I don't know. I could see the socioeconomic status on either side of the borders.
Sure. I mean, the implicit argument here is that there's there's an inconvenience to being on the wrong side of the time zone because you're out of sync with everyone else. You've got the social jet lag going on. So wouldn't you imagine that all things being equal, that people who have the choice to be on one side of the inconvenient time zone or the other would choose to be on the slightly less inconvenient side of the time zone? Well, then therefore there's supply and demand, and they might be a little bit wealthier and better off.
But they addressed that, and they said that they couldn't detect any kind of geographic shifting as a result of those issues, that the populations appeared to be quite stable, and there wasn't a lot, what was it called, cross-bordering movement. The thing that struck me was that I think that there are differences when you think about the populations and the occupations and really what they're doing, what their work is and what their daily living is when you do comparisons of the different borders, because the eastern border, the eastern central border, goes down a part of the country that's pretty much more urbanized than the central mountain border. And I think that could account for maybe not the differences within, but those are large differences in terms of perhaps health status and productivity status. The other thing was that they chose to restrict individuals to be included in the analysis who were sleeping between 2 and 16 hours. So they excluded people who had on average, reported less than 2 hours the night before, or more than 16 hours the night before in that time study. And it seems to me that those are pretty extreme.
It's a wide window.
That's a wide window. Yeah. And even if the window, it would seem to me that people could be manifesting some sort of a disease on either end of those extremes. Sure. I mean, I think it might have been a little bit better to restrict it to maybe 12 hours or maybe 10 hours.
So the other thing was that, the measure of sleep. I think I generally buy the sleep argument. I mean, that generally holds together for me. Although I will say, it's a self-reported measure, self-reported sleep, and I could see. Obviously, there's misclassification in self-reported sleep, but I could see it being differential. I could see that if you are on the side of the border that's got the later darkness later or earlier, you might actually remember the amount of sleep that you're getting differently. And so I could see the misclassification not just being non-differential, which would bias towards no effect, but I could actually see some differential misclassification that might explain those differences.
Interesting thought.
But generally, I do. Sorry?
Yeah, no, just saying interesting thought.
I do buy that there probably is some differences in sleep. Where I don't necessarily buy it so much as the health outcomes, right, where I think that's a bit of a bigger leap because, as Don says, we don't have the individual level data. We're looking at more of almost an ecologic measure of health on either side. And there, if there's a 19-minute difference in sleep, I would not expect that to correlate or to translate, into large health effects. I would think those would be pretty small. And if that's the case, if those are small effects, then all of these issues that we talk about around measurement error and differences between the populations, it's going to require less differences between those populations to explain those small observed differences in health. And so I'm not as convinced by the health effects that they present. They did something really nice, which we really like, which is they did these placebo tests or negative control tests, where they looked at things that shouldn't be affected by differences in sleep pattern, like HIV or some cancers. And there they would say, okay, and there we didn't find anything. But if you look at them, there's so much noise in those numbers that the actual values they don't sort of look exactly the same on either side of the border, and the differences aren't that different from the differences that we see in the health outcomes that they say are different, like diabetes. So I'm just not totally convinced.
Well, I think I would agree with you about the sleep. And one piece of evidence that increased my confidence was the fact that the sleep differential disappeared largely when you looked at the unemployed population, for whom maintaining parity in like wake sleep times with the adjacent time zone would be less important.
Yeah, I think most people sleep differently on the weekends than they do during the week.
Exactly. And once you retire, you probably don't have to worry about getting up at the same time as the people in Lubeck.
Right.
Yeah. So one other point I wanted to raise about this, and I'm not accusing these authors of anything at all. I just thought it was an interesting time to raise something that we've not talked about before, which is, are you guys familiar with the term harking?
Yeah. Hypothesis after results known? ING?
Hypothesizing after the results are known?
Yeah.
So the idea is that, and this is, I have to admit, this is kind of the way I feel like I was taught to do things when I was first learning research, is that essentially you look at the results, then you take the results and you tell a story. Like you have to make up some story about the data, and therefore you end up coming up with the hypotheses after you already know what the results are. And when you do that, you end up obviously making a coherent story that fits when in fact not everything necessarily fits.
Right. It's not necessarily dastardly, though. I mean, this is a hypothesis generating approach.
It would be fine. It would be fine if it was left to hypothesis generating as opposed to hypothesis testing. Mm-hmm. But I think the problem becomes that people do this as hypothesis testing. And I did find myself wondering whether all of these negative placebo tests and all these different mechanisms they looked at, were these all pre-specified ideas that they had where they said, look, if this does have an impact, it should change X, Y, and Z, and it shouldn't change, A, B, and C, or was it sort of after the fact? Now, again, I'm sure they did a great job, and I'm sure they did it, specify it all beforehand, but it is a case where, I think you do have to be really careful when you see these effects that, to me, they interpret them as negative. I would interpret them as kind of the same as the ones they interpret it as positive. I just think it's something to kind of think about.
Mm-hmm.
Mm-hmm.
All right. Anything anyone wants to bring up before I take the last word? Oh, by the way, do we have reason to believe that 20 minutes difference in sleep would be that important? I actually don't know.
I'm a lot crankier when I get less than. If I'm deprived of 19 minutes of sleep.
Yeah. Crankier.
If I'm deprived.
Okay.
I'm just taking a little shot at you there.
I know.
Don.
I just chose to ignore it, Chris.
Okay, so I did want to end. I seem to have this obsession with. I seem to have this obsession with the size of the introduction.
You do.
And you notice this introduction is massive. It's pages of, all right, where they give what we would normally put in the introduction. They give what we would normally put in the discussion, mm-hmm. the hypothesized mechanisms by which this should work, and then they give the results in the introduction.
Yeah.
It's like such a different way of thinking about things.
Yeah.
But unlike, I don't know, I got the sense, Don, you found this a little, it was not your favorite one to read. I feel like
it was long.
We in the epidemiology world should be forced to read one economics paper per year, because I actually think it's very, they are so detailed in the way they think through this. You can't just say we tested a hypothesis. It's got to be, here's the mechanism that we think is going on. Here are the 10 different experiments that we're going to do with the data that we have. I think it's actually very thorough and mm-hmm. kind of refreshing.
Mm-hmm. Mm-hmm. But a different publishing model.
I also like the fact that they... What?
A very different publishing model, because the medical journals would not tolerate, 20,000 word papers. I don't know how long this was, but,
yep.
But it was pretty long.
If you gave me back my 19 minutes, I would have enough time to read a paper this long.
I don't think you would, actually. That's the problem.
No, I did save them all up for the end of the week.
I also love that as economists, they refer to sleep as a commodity.
I know, I love that. Yeah. I noted that also.
Brilliant.
That's
it's a commodity in high demand is what they said. Sleep is a commodity we all demand.
It's like butter.
I certainly demand it.
Pork
the
bellies.
other thing was, did you notice there's no ethics statement?
Yeah, because they didn't study any patients.
No, I know, but normally you say that, right? You say... we didn't do
maybe in economics it's just assumed that that's the baseline, because they're just dealing with aggregate numbers and reports.
I just found it interesting.
Yeah.
Was there an ethics statement in the ADHD paper?
There must have been.
I wonder, because they also looked at aggregate data.
We should go back and
fully
take a peek.
anonymized.
Yeah. Huh. All right, I'm going to do my introduction to segment 2. You guys go look it up.
Okay.
All right. So let's move on to our second segment, where we want to talk about an article that came out in the British Medical Journal, and it was entitled "Low Risk Pragmatic Trials Do Not Always Require Participants' Informed Consent" by Raphael Dalrey and colleagues. And the argument that they made in this article is essentially that we desperately need real-world evidence that the drugs, the interventions, the whatever it is we're trying to test, we need to know about how these work in the real world, not just how they work under the often very contrived and controlled environments that come up in clinical trials. And this is something that we have talked about, almost complained about at various times on the podcast, that trial populations generally don't represent the general population, and the conditions under which trials are conducted don't often represent real world conditions. And so we often get results from trials that don't really tell us about how drugs are going to work in the real world. And the argument that they make is that, and I'm quoting here, low-risk, pragmatic, randomized controlled trials pose no or minimal incremental risk compared with usual clinical care and are typically head-to-head comparisons of medicines that are routinely prescribed according to their marketing authorization. In other words, they're saying, if all we're trying to do is test medications that are already approved for a particular condition, we just want to compare them head-to-head, figure out which one is best, so we're not increasing risk, this is a decision that a clinician would make anyway, then in that case, it's essentially just like routine care. We're not increasing risk for these patients in any way. And in that case, they say, and again, I'm quoting here, should we then consider including participants in low-risk, pragmatic, randomized trials without seeking informed consent? Is this approach ethically feasible? And they go on to give some rationale for this, some approaches to how you could go about this. But the question is, essentially they're making the argument that there is an imperative to get better evidence by removing the need for consent. Oh, by the way, I should back up and say the reason they're saying we need to remove consent is once you have consent is one of the reasons why the participants in trials don't look like the patients that these drugs normally are applied to, or these behavioral interventions or whatever it is are applied to, is because once you have to go through a consent process, we lose people.
Right, and you've biased the sample already.
Yeah, biased is probably not the right word. We changed the generalizability. And so the question becomes, if we were, Don is giving me a look.
Why is that different?
Because Chris is giving me a look.
Because you can get a perfectly valid answer to the question of the effectiveness of a drug in a particular population, even if that population is just not the general population.
Yeah, I agree with Matt.
So you get the right answer for that population. And he's agreeing with me just because I'm slipping him some money under the table here.
Transatlantically.
Okay.
So the point here is that if you have the need for consent, those trials are never going to represent the general population. Now, there are other barriers, of course, to getting a population that represents the general population, which they do note. But the point that they are trying to make is, in these very low risk situations, is it ethical to simply say we should be able to do away with consent for these types of studies?
Makes me nervous.
Yeah. So hum a few more bars of that. What do you mean?
Yeah, I think it's based on a presumption that I don't necessarily agree with, and that is that there are equivalent therapies, whether it's medicine or whether it's a behavioral therapy. I think that can be true in a general sense, but as a clinician, I realize that a lot of times what appears to be equivalent medicines, what appears to be equivalent interventions, are not such for an individual. And it may be that the particular individual that I would like to enroll in this particular study would be slightly better served by receiving the other quote unquote equivalent medication that I am either have been randomized not to provide or am randomizing for this person not to provide. And to do that without the consent of the individual, I think it's disingenuous, and I think is potentially dangerous, because my motivation will be not solely to serve this individual. It will be also to make sure that the science turns out to be as good as it can be. So I've got a conflict of interest in that instance, and a consent form informs the individual to whom this applies that I have that conflict of interest, and I think it's important for them to know that.
It seems like they're they're conflating two things here, where there's the issue of generalizability and to what degree do we lose generalizability through the consent process? Then there's a second issue, which is whether there are certain trials that could not be done without a waiver of consent, and those are separate issues entirely, and we can debate them as totally separate entities.
Yeah.
Right, but I think we're talking about cases here where you absolutely could get consent.
Yeah.
You're just worried that getting consent is going to change your population.
So I'm curious about like can we put an example behind this? Like, I mean, what if we wanted to do, for example, a randomized controlled trial of patients who've got streptococcal pharyngitis, and we're going to randomize them to get amoxicillin versus penicillin, right? Or amoxicillin versus Keflex to make the difference a little bit more stark. Mm-hmm. And we would think that both of those would be pretty reasonable treatments. Amoxicillin is the gold standard. Keflex should work too. But is that a situation where you could make the argument that this is a situation where we would waive consent because it would be, I don't know why, because
are both drugs approved for use for this condition?
I think so.
Yeah. I mean,
amoxicillin surely, but I don't know about Keflex.
And is this a decision that a clinician could make on their own, independent of the study?
Yeah. Yes.
Yeah. So I suppose in that case, the argument
all right. But what if the patient had a history of an allergy to cephalosporin?
Okay, so there's a risk, right?
Which is a risk, and that you need to include in your clinical decision making. And if you are being affected by how to randomize that individual, you might incur a greater risk to that individual, and that the patient needs to know that.
Because how would this then go down? Like the clinician writes a script and says, I want to give this patient amoxicillin because they're allergic to Keflex, and then the macro master up there who's designing this trial, unbeknownst to the clinician or the patient, randomizes them, and he gets amoxicillin or Keflex and has an allergic reaction.
Yeah.
I suppose but you would never prescribe the drug to a patient with that.
Correct.
Right. So the clinician would say
that would be an exclusion criteria. So I don't know that that's a true
but how
problem.
How would the trial people know that? Right? How would the trial people know that? I mean, it could well be that the clinician would have documented in the EMR that this patient is allergic to Keflex, but it's also possible that they wouldn't have done that. I'm sure it could happen all the time that a patient say, I can't take Keflex, I think I'm allergic to it, and the patient says, okay, I'll give you amoxicillin instead, and they don't enter that in the allergies field of the EMR.
But hang on, they're not. The idea here isn't that you're not doing anything. The trial doesn't suddenly become, we're just going to randomize patients to get a drug. You'd still do all the same things that you would do for a trial. You take a history, you determine whether or not the patient is eligible. You would then, if they met the inclusion criteria, randomize them. You just wouldn't seek the consent to do that. So I don't. I mean, I share Don's concern. I'm just saying I think we're conflating some things here.
Mm-hmm. Mm-hmm.
So when I think about this, I went the exact same place you did, Don, which is I don't know. I'm not comfortable with this because I think that this is it has the potential for a slippery slope, and I know slippery slope arguments are terrible arguments, but I don't know where this has the potential to be abused, and that's part of what I don't like about it. If you pan back out and move away from the line, there are certainly cases where I see no problem with trials that don't involve consent. So,
out of hospital defibrillator.
Well, no. I move even further away, like lower risk, like a health systems intervention, where we're just going to change, the way that we set up the hospital and see if it has an impact on, patients' willingness to stay for treatment or whatever it is. These sort of really low risk stuff that's really just rearranging the way the healthcare system works as opposed to providing drugs. And I should say we have done these types of studies. We do studies where, there is going to be a rearrangement to healthcare systems, and we just simply take advantage of that and look at the impacts. But my concern is when you start getting into drugs, when you start getting into
strategies,
interventions, that are beyond sort of behavioral changes or structural changes, I think that has the potential to be abused. And I worry that we don't have the best track record of not going up to the line and going past it as a field. And I think that's where my worry comes in.
Yeah.
Yeah, I'd agree with that.
I agree.
Yeah. I mean, I just, if you're dealing with individuals, and allocation into a study is part of your decision making, I just think it's wrong not to let that individual patient know that that's part of your decision making.
So what if the you're going to do, let's say you're a government and you want to do a cash transfer intervention where you're gonna provide money to people who are below a certain level of poverty index, and you're going to see if that has impacts on people's school enrollment, on attending a healthcare center, whatever it is. But you only have a limited amount of money, and so you decide that the best way to allocate this is just essentially through a lottery system, which is randomization.
Right.
Is that then ethically justified to do without consent?
I think that would probably fall in the category of things where you could go to an IRB and request a waiver of informed consent.
I agree with you.
Well, what's the risk?
I think
it's impractical to do.
That's my point. I don't think there is risk. And so I think if you can clearly show that there is no risk, then, or that there is limited risk, there's never no risk, then I think you're on safer ground. But I think once we start getting into drugs, the three of us suddenly got
nervous,
far less comfortable.
Mm-hmm. Yeah.
And I think it's because we don't always know the risks of drugs, even when they are established drugs.
Yeah.
And maybe that's the reason why this is less comfortable for us.
Even established drugs have side effects that don't become known for years.
Yeah. Right. And I think we've had a number of drugs that have ended up being taken off the market much, much later because we didn't discover the side effects until much later on. So and so maybe that's it. Maybe what we're saying is behavioral interventions, we might be much more comfortable, or structural interventions to health systems, we might be more comfortable. But when it comes to drugs, we're not there.
Yeah, I would agree.
Yep.
All
right. Last segment. Well, how about that?
Chris, so you want to do the intro then?
Well, we're gonna talk about our favorite wacky and weird science example. This is the part of the show where we just get really irreverent and we share stuff that we find just charming or amusing in some way.
Or wacky.
And I'm gonna start.
No, this is
amazing and amusing
segment.
Wild and wacky.
Wild and wacky.
Amazing and amusing. Chris, I'm going to start because you're already talking. So why don't you go first?
So apex predators of the ocean. Who are the absolute two top badasses? I can't say that.
Great white.
Okay, great white is one.
Dolphins.
No, but you're on the right track.
Tiger sharks.
Big dolphins, which are called
Shamu.
Yes.
Namu.
Yeah, orcas. Yeah. Okay. So those are the two the main apex predators. And I suppose you could add in sperm whales too. Those are pretty big, but we think about them in a different category because they go and eat giant squids deep down.
We do, or you do?
They do. They do. So there was there's a lot of interest here about great white sharks in Massachusetts because we get a lot of seals now because we're protecting them, and now we got a lot of great sharks that eat the seals, and eventually everybody knew that someone was going to get chomped. In 2 years, somebody got chomped, and then last summer someone got killed by a great white. So this has sort of gone from a hypothetical concern to an actual concern now, and there are great whites also increasingly seen off the coast of California. And I was just in San Francisco last week, and when I went to Stimson's Beach, beautiful spot. Stinson Beach, excuse me. And there are now warning signs on the beach about the great whites saying, watch it. So the question is, like, which of these two apex predators is kind of like the more like bad? What am I allowed to say?
Bad. Just bad.
All right. So off the coast, there are, there's these islands called the Lesser Farallon Islands, which I've never been to, but apparently are beautiful. But there's like lots of great whites swimming around, eating the seals, particularly the elephant seals. And there's part of the year where the elephant seals haul out to basically have pups. And so that is open season for the great whites. It's like ringing the dinner bell, and it's a giant buffet for about 4 months where they eat them. And there are lighthouses on the Farallon Islands where they do observations to watch the predations, and it's pretty obvious because the water gets all bloody. So it's not subtle when one of these elephant seals gets chomped. And then they also have a bunch of marine biologists who run around in motorboats and tag the great whites, and have set up this system of sonar buoys all around the Farallon Islands so they can follow Henry and Juno and Lucy as they swim around and eat the seals. Now, this is all by way of background, because this fascinating phenomenon has been now observed 4 years running in the Farallon Research area, where they be following the great white sharks, doing their thing, eating the seals, swimming around the Farallon Islands, and they're there and there and there and there. And then a pod of orcas will show up at the Farallon Islands, and the great white sharks disappear.
Really?
They are gone.
Wow.
They are out of Dodge City before you can say boo. Like within hours, every great white shark is gone from the waters. And these are pretty big islands. And so the sharks must be very acoustically aware of whatever echolocation noises the orcas are making, because they make a bloody racket, where they're pinging all the time. And the sharks also get eaten by orcas. And so the sharks leave immediately, and they do not come back for months.
Wow. That's amazing.
They're just like, we're done. See ya.
It's like a motorcycle gang coming into
cool.
town.
Right. It was so cool. I was like, wow, there you go.
Very cool.
Turn tail and run.
There you go. All right. Well, I'm gonna go second. Make Don go last. So mine comes from the BMJ Christmas edition from 2017. BMJ Christmas edition is one of our favorites. Although I will say this one is not. It's not as wacky as some of the other ones. This one I actually think is holds up as some decent science, but asks an interesting question that I think we will all be interested in. So this was from 2017. It was by I got the name wrong. So it's Zorana Zupan and Alexandra Evans and Dominique Laurent Couturier. Et al. There you go. And the title of their article is Wine Glass Size in England from 1700 to 2017, A Measure of Our Time. And they looked at whether or not, in fact, wine glass sizes had increased over this time period as we are now consuming, and whether it has a role in the amount of alcohol we are all consuming. And so the way they did this was, so they start off by noting that wine consumption has increased fourfold between 1916 and 1980, and then almost doubled between 1980 and 2004. And so they wanted to look at wine glass capacity as an initial step to trying to understand whether potentially you might have a health intervention by reducing wine glass size, because that was one of the things that has been studied in the past, things like smaller plates. And so what they did was they got measurements of wine glasses from 5 sources. So they went to the Department of Western Art at the University of Oxford, the Royal Household, where a new set of glassware is commissioned for each monarch so they got data from 1808 to 1947. eBay, the catalog from Dartington Crystal, an English glassware manufacturer, and John Lewis, the department store with the largest online selection of glassware. And they stitched all this data together, and they found that wine glass capacity has increased from 66 milliliters in the 1700s to 417 milliliters in the 2000s.
Wow.
And the mean wine glass size in 2016 to 2017 was 447 milliliters with a standard deviation of 167. So the increase was generally pretty gradual until the 1990s, when it became pretty marked, as they say.
Wow.
And so they say their findings suggest that the capacity in England has increased significantly over the past 300 years, with including this marked increase in the 1990s. And however, they do note some of the limitations of these studies, in particular that smaller wine glasses may have an endurance advantage over larger ones, which could explain their findings. So smaller wine glasses may be less likely to be damaged and therefore would stay in these collections from the older time periods. There was also a glass excise tax levied in 1746 that led to the manufacture of smaller glass products. I don't know that that's a limitation, but just one of the things they noticed. Anyway, I just found it fascinating. I think they put this together for the BMJ Christmas edition as a bit of a humorous piece, but I thought actually it was pretty clever.
Was there a difference between red and white wine glasses?
Didn't say. Didn't say, but I would assume there would be, right?
Yeah, you would think so.
Experience drinking wine.
I wonder if like whiskey tumblers could be like a control, because they're pretty robust, right? And you wouldn't think that they'd be as sensitive over time because they're like thick crystal glass, I don't know.
Yeah, it's a good question. I don't know.
Cool.
All right, Don, what do you got for us?
All right. So there's a paper that I came across called Risky Business by Stephanie Johnson et al. From the Proceedings of the Royal Society. Researchers from Leeds, University of Colorado, and Bilbao University in Spain on toxoplasmosis.
Wow, they made a movie out of this too.
Did they?
Yeah.
Not that I'm aware of.
Tom Cruise.
Risky business.
So in any event, they were interested in seeing whether you could detect a behavioral change in human beings as a result of being infected with toxoplasmosis. Because it is well known, apparently, that there are behavioral changes in mice that get infected with toxoplasmosis, which is a parasite that can infect almost all mammals, but the definitive host is a cat. And a cat feces contains the infective cysts. And apparently cats can produce up to 250 million cysts per week.
Wasn't this a central part of the movie Trainspotting?
I don't think I ever saw that movie.
I feel like somebody got really sick from
So when mice become infected with toxoplasmosis, apparently they lose their aversion to the smell of cats, and in particular, the smell of cat urine. So it's this evolutionary development in the favor of the cats that allows them more successful hunting of the mice when the mice become infected. And it's the cat that is the only mammal that actually produces these cysts. So
the cat is not affected by it?
Not like other mammals, because what happens is that all other mammals are a dead end host for this particular organism. It has a complete life cycle in cats. So these authors asked whether there was a correlation between risk taking in humans and the detection of IgG for toxoplasmosis in the saliva. So they did an analysis in 1,495 university students where they measured the saliva presence of IgG for toxo, and they found that those individuals who were positive for toxo were 1.4 times more likely to major in business, which they consider to be a more risky outcome, and 1.7 times more likely to emphasize entrepreneurship within business, and 1.8 times more likely if they were attending a business meeting to have actually started a business. So their bottom line is that these people's behavior may be being induced, their risky behavior, risky business, risk-taking might be induced by being infected with toxoplasmosis.
So not bungee jumping.
So what?
Not bungee jumping, not
no.
You know,
starting a business and being an entrepreneur.
Not diving with sharks, but entrepreneurship.
Yeah, I think they may be reaching a little deep there.
I thought
it was fascinating, that whole thing about rats.
Yeah,
apparently
I'd heard that too.
They become fearless towards cats.
There's some other. It's the
cysts in the brain.
It's the same thing with the Balis ascaris procyanus, the roundworm for the raccoons, and then that they're omnivorous and they eat mice, and it causes encephalitis in the mice, and so they become like sitting ducks for the raccoons to eat them up.
Right.
And so it like makes, it completes the cycle for them.
Poor mice haven't figured it out yet.
Yeah.
Chris, you love talking about parasites, don't you?
I sure do.
Oh, so do I.
When I think it was like I probably knew you for maybe a year when I heard you utter the phrase, "Ooh, that's my third favorite parasite."
That's awesome.
And which one was that?
I have no idea. But I'm sure Chris does.
I don't know, but I think my favorite one is still Strongyloides stercoralis. But
obviously,
it's a good one.
Strongyloides. Okay, well, that is the end of our program. If you've got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthEX, or you can tweet me at @ProfMattFox, or you can tweet Chris at @ID.Gill, or Don at @DTheo1. Or as always, you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.